CLI is critical limb ischemia, has several definitions, but in its simplest form, it's any type of patient who has a change in status that is gone from when I walk, I have crampy legs to one of rest pain. In its ultimate form, critical limb ischemia is a chronic disease that can effectively start to eat away your tissue. And so whether it be by ulceration or frank gangrene, tissue loss is the ultimate endpoint of critical limb ischemia. So in its definition, it's usually driven towards folks with rest pain and for ulcer and gangrenous toes. The evaluation of patients with critical limb ischemia and most of the things that we try to do, when you look at how best to treat folks, it usually falls into probably one of three categories, right? So it's the simplest to the more invasive. And so the simplest thing is, when did it start? How long has it been going on? What is the significance of what's happening? You'd be surprised that folks who have terrible ulcers have been living with this ulcer for over a year, if not longer. And when they come to you, they actually have, a quarter of their forefoot deep in ulceration. And it's remarkable to me how they can move on from day to day without having that fixed for so long. And so, the simplest thing that you need to do in patients who present to you with critical limb, and if we just take ulcerative, kind of the Rutherford 5 group, you need to start treating the simplest thing, which is the ulcer. So in my approach to patients with critical limb ischemia, we look first what the foot looks like. What does the limb look like? Is the ulcer deep? Is it not deep? We always get our wound care specialists involved. We also try to look at the patient in a medical standpoint. How best are they treated medically? Have we treated their diabetes, their renal failure, their hypertension, coronary disease to the highest degree? What is their ambulatory status? Are they a person who basically sits at home and does very little? Or are they a very active 68-year-old who wants to run around with their grandkids? So each one may have different outcomes as to how you want to be aggressive here. So beyond the medical therapy and the wound therapy, then the last thing is, what's the best therapy for them? Is it a surgical revascularization or is it an endovascular evaluation? And the workup that we have in our institution, apart from the physical evaluation of the patient, is also to do some form of non-invasive imaging. And so in the non-invasive realm, we do three things, or at least three opportunities for evaluation. First is a non-invasive study. The duplex that we have, we're a duplex-driven lab, not a PVR-driven lab. So we do ABIs and duplexes, and we really look at the anatomic of the artery, not only for a calcific burden, but also the flow and the flow dynamics for various locations, whether it be above knee, at knee, or below knee. And then if we're ever in, we don't understand, let's say the ABI is supranormal, we'll try to exercise them. If we can't exercise them because of their critical limb, and we know based on their presentation they have disease despite a normal ABI, then the next step is either ad hoc, take them to the cath lab for an angiogram, or if there's a question about how much and how, define the anatomy, I like doing CTs or MRs to define the anatomy so that we can know before we even get in there whether or not we're going to do kind of an antegrade retrograde approach, or if we're just going to do an antegrade approach because it looks like it's mostly multi-level but stenotic non-occlusive disease, or if it's a very long level CTO or chronic total occlusion, coming from above and below to recanalize and reconnect those dots. Usually is very helpful to understand what you're up against before you get in there. So that's kind of our approach to most patients with CLI. Most of these folks have diabetes. If not, they all have hypertension, they have coronary disease. So the surrogate therapies for all patients with CLI, to include coronary patients, would be strong therapy in hypertension control, ACE inhibition for folks with diabetes to control renal failure. Those that have renal failure, if they're not on dialysis, they're going to end up on dialysis. Cholesterol control, which has, with the ACE inhibitors, statins have been shown not only to effectively lower cholesterol, but they have this so-called pleiotropic effect of an anti-inflammatory, so it limits progressive disease. If they're not on an aspirin or a dual antiplatelet therapy, so-called DAPT, whether it be Plavix or Prasugrel, those things need to be considered in your patients with critical limb and all patients with vascular disease. But moreover, the next step is kind of surrogate phosphodiesterase inhibitors, i.e. pletal. The challenge with pletal is that once you cross over into the Rutherford 4 rest pain and limb loss or potential limb loss through ulceration and gangrene, the pletal, although it's useful, is not something that will stave off some form of revascularization. So medical therapy in all of those surrogates and that umbrella of medical therapy is all just part of the puzzle to then ultimately get you revascularized, because the next big step is going to be some form of revascularization, whether it be endovascular, which most of us gravitate towards initially, or surgical revascularization, should that be the best one. I like the question of when do you stop, because, tongue-in-cheek, we always stop one short of a complication, right? So if we can do that, then you've won. And the victory for the patient, honestly, is revascularization. And the revascularization strategy that most of us have tried to do, it used to be a kind of a, it wasn't very popular, and then it became more popular, and it has really become championed now by Jihad and his group at Metro, which is the angiosome concept. So in the past, we would take the surgeon's mentality of approach to revascularization to the lower extremity. And the surgeon, not that this is a bad thing, it's just when they did distal bypasses, they would choose the best conduit to the distal best receptor vessel. And if it was a plantar vessel, despite a great toe ulcer, they would still do a plantar bypass, and it would still improve the great toe ulcer because it got you so-called inline flow. And so for many years we were focused on inline flow, but with the angiosome concept, what most of us have gravitated towards is you may find folks that have a PT that's open but an incomplete arch, and they have a great toe ulcer. So in those folks, we really want to try to open up the anterior tibial artery to give you the best inline flow to that great toe to heal the ulcer. So many of us will now either reconstruct the arch to give you the great toe, the first digital artery off of the arch, or come straight down the AT to revascularize the patient. So in our revascularization strategy, what used to be considered best therapy, inline flow, is now considered best therapy, angiosome-directed flow, to help direct flow to this specific territory that is ulcerated or gangrenous. And when to stop? Look, if you can't get across and you can't come retrograde and there's a lot of issues, never burn a bridge. And one of the things that I've championed in my talks here and elsewhere is you got to learn when to quit. And quitting is not failure. You got to do what's right for your patient. Come back, fight another day, take a breath, buy a vowel, as I say, and come back and do something else. But surgery is always a very viable approach in many of these cases. If they have conduit and the surgeon is willing to work where you've maybe muckered up an artery, then it may actually salvage your patient's foot. But the beauty of what we do in endovascular therapy is technology has grown to such a great degree recently that now we have dedicated therapy specific for the tibials, whether it be coming around a horn or retrograde or antegrade now down a pedal. I think you have pretty good opportunities to get across most lesions. And as long as you can revascularize it safely, you don't have to stop. And once you know that you have flow, and you can stop at that point. The downside is when you can't reconstruct something, or if you do reconstruct it, what's the durability of it? And I think that's what we're all struggling with, is getting better scientific data as to when you do if you do an intervention and it works, is it a one and done deal, or are you coming back 3 months later to do the same thing again? And I think that's what a lot of us who are on podiums need to try to champion. We need to know that scientific data set much more than we currently do. Rate of amputations is an interesting question for CLI, because I think we've already seen a decline in the amputation rate. Now that decline in amputation, if you talk with a lot of endovascular specialists, it kind of coincides with the boom, the growth of endovascular therapy. It also kind of coincides with the higher degree of education in our patient populations. So I think both in concert have led to a decline in the amputation rate. So if you were just take a pragmatic approach in the next 10 years, would you think that that line will continue to decline? And my expectation is it will continue to decline. Why it does so is still anybody's guess. I think we're still going to educate to a huge degree all the folks who have the potential risk for critical limb ischemia, those folks who have coronary disease, neurologic disease, i.e. carotid disease, who have had prior strokes, those with peripheral arterial disease diagnosed, either claudicants or those who present fresh out of the box with CLI. Once you identify the patient, once you identify the same patient population which has a systemic disease of atherosclerosis, you now have to educate. As much as we educate to avoid strokes and heart disease, you have to educate with peripheral arterial disease. And I think that by virtue of that education, you'll see people present a lot sooner than the one we described earlier on, which is they present with a half-eaten foot because they haven't had their they don't take off their shoes or talk to their doctor for 6 months. But at the same time, I think that the dedicated therapies that we have, whether it be angiogenic, directed therapy for pedal, long-term success pedal interventions, whether it be pedal loop reconstruction or just anterior tibial, posterior tibial, just simple tibial reconstructions, as well as pharma-driven therapies, will all drive the amputation rate lower, because not only are you going to be revascularizing them, but you're going to have a much more durable outcome as to the procedure that you did, which means it has less healthcare dollars being spent downstream and a better outcome because they're still ambulatory, which may make, a 60-year-old still a productive member of society, which ultimately saves you and I tax money.